This video is on renal cell carcinoma. Before we get stuck in, let's look at the different types of renal cancers. The type depends on the area affected. This image recaps the different sections of the nephron, so the glomerulus, proximal convoluted tubule, loop of Henle, distal convoluted tubule, and the collecting duct. Cancers of the proximal convoluted tubule, such as clear cell or papillary carcinoma, are the most common. If the DCT is affected, it is likely a chromophobe carcinoma. An oncocytic carcinoma arises in the cortical collecting duct. In contrast, the medullary collecting duct gives a collecting duct carcinoma. It is important to understand the signs and symptoms of renal cell carcinomas. They could be from directly affecting the kidneys, constitutional symptoms, from paraneoplastic syndromes, or from metastases. So let's go through each. Painless haematuria is common, and this is due to the tumor damaging the glomerular basement membrane. But this can be either macroscopic or microscopic and picked up on a urinalysis. Phalanx pain results from stimulation of T10 to L2 nerves. A left-sided varicocele is caused because the left renal vein can be obstructed from the tumor, and the left renal vein drains into the left gonadal vein. It's left-sided because the right renal vein drains directly into the inferior vena cava. But the inferior vena cava can be obstructed, resulting in peripheral edema, ascites, and hepatic dysfunction. As with all cancers, there may be constitutional symptoms such as fever, weight loss, and malaise. Paraneoplastic syndrome, specifically erythrocytosis, can cause headaches and increased risk of clots. Hypercalcemia has the iconic symptoms of abdominal groans, renal stones, psychic moans, and painful bones. Stauffer syndrome is interesting and is when there is hepatic dysfunction without metastases. There may also be symptoms due to metastases, commonly to the lung, liver, bone, and the brain. The most important diagnostic investigation is an abdominal CT looking for masses. By the bedside, a renal ultrasound can be done and urinalysis can be done looking for microscopic haematuria and cytology. Bloods include FBCs looking for anemia but rarely erythrocytosis, UECs to gauge renal failure, CMPs that may show hypercalcemia from bone metastases or paraneoplastic syndrome, LFTs to detect liver metastases or Stauffer syndrome. Imaging for metastases can be conducted, specifically a chest X-ray or a PET scan. Treatment usually requires a nephrectomy unless there are bilateral tumors or there is poor function of the contralateral kidney. Unfortunately, there are often chemo-insensitive tumors, so chemotherapy is not appropriate. Palliative radiotherapy can be given. Thank you for watching. If you learned something, please tell a friend who may also find it useful.